Thank you. Yeah, and thanks for having all of us. And just to give you an idea of who we are. So I'm Dave Ederer. I work here in Atlanta, Georgia at the CDC. Um, and I'm an epidemiologist, but we're joined by Meghan Mitman, who's a principal at Fehr and Peers. And so I know is a public health group. Fehr and Peers is one of the really forward-thinking uh, architecture and engineering firms, so we call them in our field. And they've done a lot of great work, and a lot of that is thanks to Meghan. She's been a real leader in safe systems, and without knowing it, I like to say she's an awesome public health professional. And so we've got Meghan, and then we also have Tiffany Smith from the Vision Zero Network. Uh, if you don't know Vision Zero Network by name, you do by their work. They've really launched a lot of this movement here in the United States. I've known about them since they got started, and Tiffany was one of their, I don't know if their first hire, but first specific hire of a public health person, if that's correct, Tiffany. But I know they wanted Tiffany because she had a public health background, and she brings this public health lens to their work. And having known Vision Zero Network since the day they started, and actually we did one of our first webinars together way back in 2014 or 15. I really appreciate, as a public health and transportation person, um, Tiffany bringing these two things together. It's literally a dream of mine to see more public health people doing this work, and Tiffany is an embodiment of that. So let's see if I can get a slide. Sorry, I'm going to share my screen and then put my slides up. Sorry here, and we'll get started. Oops. For some reason, there we go. I'm actually calling in from a public health conference right now, so sorry for the technical issues. So anyway, I already introduced myself, but and there's a couple people that have seen early iterations of this presentation, so you may know the answer to this one. But this is the first director of CDC. I think he was actually quite involved in this section of APHA back when it was the public health engineering section. This is a guy named Dr. Mark Hollis. Dr. Mark Hollis. He was the first director of CDC, not a physician. He was a civil engineer by training. And he's one of two people to not be a physician and to lead CDC. And he did that because at the time, there was a clear professional link between public health and engineering. And engineers were really on board with public health and were part of the fight. And so Dr. Hollis was key in altering the built environment to prevent malaria. And that's why the CDC is here in Atlanta, because malaria was endemic to Atlanta. And how did they primarily solve that in this country? They made it harder to transmit the malaria virus by altering the built environment. So in keeping with the theme of engineers and public health, this is not a new idea. It sometimes seems new, but it goes back to the origins of this section, the environmental health section, which used to be the engineering section. And in the 1930s, people were debating how do we train this new generation of engineers for public health? And they called them public health engineers. And so I loved how they were thinking about it. If I'm an engineer by training, if you talk to engineers, they really like to get into the details of what and how we build things. And I think we need to move beyond that and talk about why we build things. And that is a public health perspective, in my opinion. So at the time, they recognized public health engineering as an essential calling, the prime object of which was to control the factors of the physical environment as they especially affect the health and welfares of aggregates of people. And I think we can apply those same ideas to civil engineering today, and specifically in transportation engineering. And over my slides, I'm going to make the argument about how we might do that. So for any engineers in the room, this is a fairly standard civil engineering curriculum today. It includes 2 semesters of transportation, which is more than most undergraduates get today. So this is similar to the civil engineering curriculum that we have at Georgia Tech down the street, but we call it civil. We don't actually call it public health engineering. And there was a time when we did. And just to build on the point that I made before, there was this robust debate about what engineers' role was in public health, and I loved how this was phrased. It's not so important that an engineer knows how to build a sewer, so that they know why sewers are necessary and what results may be anticipated from the discharges of their contents without treatment into a body of water. So we can apply this to transportation, right? It's not just about why we build roads, it's about what happened, or sorry, not how to build roads, it's about why we build roads and what happens when we build them in one way or another. And if we think about the pathology of transportation safety, which I'll talk about in a second, we need to think about the anticipated results of that pathologic agent, which is kinetic energy in transportation, and really use that as our primary design criteria. So if you've been in transportation, you may have heard of this ease framework. It is still cited today. It is still in many state, local, and decreasingly in federal documents, but you still see the ease framework. It's, it enumerates a number of different key stakeholders in transportation, where we have people that work on enforcement or work to educate road users or emergency responders and engineers. They say if all those people work together, there will be fewer crashes. Maybe true, but I argue that this is just an alliterative collection of words that doesn't tell us anything about the problem itself. It applies a false equivalency between all these interventions. And as public health people, we want to work both at the population level and we want to prevent the crash in the first place. And I don't think this ease framework tells us any of those things. And so we kind of went back to the drawing board and looked at the history of public health and the history of transportation injury. And you're probably familiar with the epidemiologic triad, where the host, agent, and the environment need to interact with one another. And that can cause disease, right? And to prevent disease, we break the triad. Very simple. You might argue it's oversimplified, but these oversimplified models can teach us a lot about what we do. And it's all framed within the social determinants of health. We know that just because of where you live or your job, you may be exposed to, as the host, you may be exposed to a different agent or in a more risky environment for any particular pathogen, right? We know if you're a restaurant worker during COVID, you probably had a different risk profile than somebody who could work at home and avoid all that contact with other people, right? We can apply this to injuries, right? And people have done that. Many researchers, at the same time as people were proposing the ease framework, were proposing that we apply the epidemiologic triad to injury. So William Haddon, the first director of the National Highway Traffic Safety Administration, was a physician and epidemiologist. So the first director of CDC was an engineer, and the first administrator of NHTSA was an epidemiologist. Kind of a cool reversal, and tells you that this idea of transportation and health not being two separate fields is really not a new idea. And he said, well, guys, we need to think about this in terms of the epidemiologic triad, and was speaking to many others' work. And he said, we can think about this in the same way. So human beings are the host. The pathologic agent is kinetic energy. And so we can alter that relationship using things like 3-point seatbelts, right? So 3-point seatbelts distribute that kinetic energy in a crash along your sternum and your hips, some of the strongest parts of your body. So instead of, colliding into the steering wheel at whatever speed you're traveling at, you actually stop before that, and the force is dissipated over those less vulnerable parts of your body, right? It's better to have that all dissipated over your chest than the center of your forehead. You can also change speed limits to alter how human beings act within the environment. Tell them that maybe there's going to be more people walking around the school, so you need to drive slower. You can also alter vehicle design, and this is something we've done really well on the inside of the vehicle in this country, right? You think about roll cages, crumple zones, all of those take that transfer of energy in a crash and turn it towards the steel or the plastic or whatever might be inside the vehicle, and can sustain that transfer of force rather than going to the human body, because we're just a structure, right? And we can think about things as if the human body is a structure and it's susceptible to massive transfers of force, just like a road or bridge. So we need to think about how we can keep that force from going away from the human body. So we've done a marvelous job working on engineering design on the inside of a vehicle. We've done uh, a pretty poor job protecting people outside the vehicle. And we can do so much better when we take these ideas that we've already applied inside the vehicle and apply it to our built environment. So to build on public health ideas, I don't think we should reinvent things. You may know the health impact pyramid from Dr. Tom Frieden. He was the director of CDC during my first go around with the agency. And I thought he really explained public health interventions and how to prioritize them well. And he had two really big points that we need to emphasize population health impact and also decrease individual effort, right? If it takes every human being making a decision to be safe or healthy every single time, that we're going to have less population health impact, no matter how effective that intervention is, because people should not have to choose to be safe. They shouldn't have to choose to be healthy. That should be the base case, right? We need to make the safe or healthy choice the easy choice. We don't ask everyone to filter water at home. We do it at the source, because that exposes the population to that safe, effective intervention. And we can do the same in road safety. And I know some of the other presenters will talk about that in more detail. And second, we also have the hierarchy of controls, which folks in this section may be very familiar with. And we chose to incorporate this because it's another well-used and proven public health framework that understands the value of engineering in mitigating the transfer of a pathologic agent, particularly kinetic energy. And so we use engineering controls to protect people, especially in work sites. Occupational health and safety really, really gets this, right? PPE is useful, but it's a last resort, right? You'll see every construction worker is wearing a hard hat and steel-toed boots on a work site. At least they should be. But it's so much better if we can automate those processes at a work site and take the worker out of the equation and keep them safe. And maybe they can operate a machine remotely that digs a trench or builds the vehicle in that manufacturing facility, and that's elimination. Or we can, substitute one potentially risky situation for another. And so all of that is based on this idea of kinetic energy as a pathologic agent. We've done again another wonderful job implementing this in occupational health, right? We've taken many workers and substituted one risk for another, or eliminated the risk entirely by using good public health science. And I think we need to do that in road safety. So we took those two frameworks and kind of combined them into what we call the safe systems pyramid. If you're familiar with transportation, you've probably heard about Vision Zero. It's part of a larger family of ideas known as safe systems around the world. And so we took those two frameworks and combined them with the safe systems idea, which I argue is core public health because it's based on the idea that kinetic energy transfer is pathologic. We said we need to think about how to prioritize interventions, because if you've worked in transportation, as long as some of us have, you've probably noticed that a lot of these programs are just long lists of individual interventions that have no priority in terms of the public health science. And so we created this to help people think through different interventions in their effectiveness. And so I really wanted to focus on education and socioeconomic factors. We put education at the top because we can tell people to slow down or drive safe or do the right thing as much as we'd like. That's not going to be very effective when everybody has to make that decision every time, and when everything else is telling you to do the opposite. You may want to slow down on a multi-lane arterial, but there might be somebody behind you that is tailing you and driving really close and wants you to drive faster. And it may feel uncomfortable to drive 25 miles an hour on a road that's designed like it should be. You should drive at 60 miles an hour. Think about how many roads you've driven on, maybe in your city or your town, with 3 lanes on each side, and then maybe a turning lane in the middle. That's just as wide as the typical interstate. There's a certain driver expectancy that you build up that gets you to think, I should drive fast. And so when you see roads that are designed the same way on a highway and a city street, it isn't unusual that you feel like you need to speed up. So just telling people to slow down isn't going to work when all of that, when the built environment is created in that way. And then at the bottom, socioeconomic factors mean that people don't have any other choice other than to expose themselves to risk. And we need to think about that as transportation planners and engineers, both from the idea that when we design a road, we need to understand that maybe there's a school nearby or dense housing, but also that our decisions influence the socioeconomic factors. We make it easier to get to work. We change the underlying land values and use. And so the factors in the middle are where we kind of take a lot of the engineering measures and where we can get a lot done in the short term, kind of the low hanging fruit. So we have these active measures right at the top. So these are things that are effective, work at the individual level, but also require individual choice. So they have that lower population health impact and require people to choose to be safe every time. So an example of that might be choosing to wear your seatbelt, an enormously effective thing, and something everyone should do on every single trip. But to get to really high rates of population health impact, we need everyone to do it every single time they get in the car. And we've done a really good job of that. But even better, from a public health perspective, is start working on those latent safety measures, which achieve high risk reduction without asking people to choose to be safe. So think about those roll cages and crumple zones in your car, or automated emergency braking. No one is choosing every time they drive to have those features, but it provides a level of safety for themselves and others because it's just built into the system. But it still acts at the individual level. So we need different, when that technology is implemented, whether it's in a vehicle or in the roadway environment, in it still, someone needs sorry, it acts at the individual level. So we need many, many people to make that choice to achieve the safety value. More important, I would argue, as transportation professionals, is altering the built environment. When you alter the built environment, we don't ask people to make the choice to be safe or make the choice for other people to be safe. It's just built into the system. So we have that increased population health impact, and it's also a long-lasting intervention. So when we change the built environment, that stays for a long time, and we get that safety value for many, many years, right? If we build a sidewalk, that people can walk on it for a very long time, which is much better than putting a sign up that says, you know, pedestrians present, right? People don't have to choose to create that safety. And one of the more important things is these lower level interventions in the built environment and the socioeconomic factors make other things work more effectively. So when we change the built environment and make it easier to slow down or make it easier to walk or cycle, it increases the effectiveness of other safety measures because we're creating that population level risk reduction and makes everything else more effective. And when all these things work together, we can really start working towards that vision zero and get towards increasing public health consciousness in our work. And again, there's a lot of different choices that need to be made, but I think, you know, focusing in on decreased individual effort and increased population health impact can help us achieve a lot of the reductions we talk about and apply that public health thinking to people that may not have that public health training, but are key portions of the public health workforce. And just to give you a really quick example here of what that might mean in the built environment, as a public health crowd, focus on prioritizing interventions that reduce speed and conflict points. So I've talked a lot about speed because speed is obviously directly related to kinetic energy, right? Acceleration is squared in our physics, right? That is one of the most important factors. But we also want to reduce conflict points. So when we think about controlling the transfer of kinetic energy, there's also, you know, there's the amount of kinetic energy that's marshaled, speed, but there's also that point of conflict. So we can reduce things in time as well as space, right? So there's something called the leading pedestrian interval. It's a very common term in transportation, but you may have experienced it in your own lives. So when you're at an intersection, the walk signal starts 5 to 10 seconds before the car signal. And that allows the pedestrian to get into that space, giving them more time to cross the street, making them more visible to the driver, and it makes things much safer for just a few seconds in every signal cycle. And that's how we reduce conflict points. So it's not just conflict points in space, but also conflict points in time. We have lots and lots of tools to make the built environment safer. Roundabouts. Roundabouts are an incredible intervention if you think about how they change the transfer of kinetic energy, right? They alter the trajectory of a vehicle when they go through an intersection. So if you can just drive straight through an intersection and you blow through that red light, you're going to be driving much faster. If you have to slightly turn, you're going to have to slow down, right? And you actually have to choose to speed up because you're changing the trajectory of the vehicle. It also changes those conflict points that I just spoke about, right? When you get in a collision at a four-way intersection, you can have that T-bone crash, which is really, really dangerous. And you have that left turn conflict, which is the most dangerous movement in traffic. When we build a roundabout, we entirely eliminate those types of crashes. Well, maybe not entirely eliminate, but we make them very, very unlikely because we're changing how a vehicle moves through time and space, right? Most of those crashes are going to be relatively minor and they're going to hit themselves at a different angle and reduce the amount of kinetic energy transferred. Raised crosswalks and sidewalks are another great intervention that we need to see more of. They slow down vehicles as they go up and approach that conflict point with a person walking, right? You have to choose to speed up when you go up a speed bump, right? So it's a better way to slow people down. They have to make that, they have to deviate from the baseline for the risk. And of course, socioeconomic factors, the things we build and how we build them influence socioeconomic factors. Zoning and land use, we need to think about how to incorporate public health into these ideas. We can share data systems across departments between public health and transportation. We collect a lot of the same data about the same things, but they rarely talk to one another. And just showing support. A lot of times, transportation departments are making decisions or want to make things safer, and they could really use the public health department, or it would be really helpful if the public health department could provide them support and say, you know what, this is much better for our city or town and our residents to make it much healthier and safer. And that's important to us too. So we have the evidence for a lot of this stuff. You know, at CDC, we love our evidence. We have a systematic review of traffic calming interventions and Vision Zero initiatives. It's shown to reduce pedestrian and vehicle crashes. And more importantly, there's so many other things that this influences in terms of our health, right? A recent systematic review of randomized controlled trials in the BMJ showed that walking or jogging is as or more effective than pharmaceuticals in treating depression. If we could bottle this up, we'd be billionaires. And we can put it in all of our towns and cities right now. And if you look at all of these different interventions, they're not available to everyone. But if we build our infrastructure in a way that's safe and it makes it safe and easy to walk or jog, we can make this wonder drug, quite frankly, available to millions and millions of people. And with the different mental health crises that we're addressing as a country right now, what an incredible mandate for our work. And it's so much bigger than just reducing crashes. And I could go through the long list of things that physical activity helps you right now, 10 years into the future, and 30 years into the future. There are a few interventions that really improve our health over the life course. So it's really important that we help people walk and bike. I won't read these out to you, but try to think of another intervention that accomplishes all these things. And I find it hard to believe that you don't think you're part of the public health workforce if you can offer this to people. So if you want to check out the stuff we're doing at CDC, join us at Active People Healthy Nation. I'm going to kick it over to, I think Tiffany usually goes next. And thanks so much for having me. I really appreciate it.
Okay, awesome. Thanks so much, Dave, for your awesome presentation, and also for the great introduction of our little cohort and group. I'll just briefly introduce myself again. I'm Tiffany Smith, the Program Manager of Vision Zero Network. And special thanks to APHA for inviting us to collaborate on this webinar. We're really stoked to be able to talk about this with public health practitioners. Dave did a really good job of kind of providing a high-level overview of a bit of the work that we do at Vision Zero Network, but just for folks who aren't super familiar with what we do, we're a national nonprofit organization that helps communities and practitioners and policymakers advance and set their goals of Vision Zero, which is a strategy to eliminate traffic fatalities and serious injuries while increasing safe, healthy, equitable mobility for all. I like to kind of describe us as kind of part resource hub, part connector. And we host a multitude of learning opportunities, webinars, peer exchanges, all on the safe system approach, speed management strategies, and like how practitioners can be more intentional about integrating health equity into their roadway safety work. And so, yeah, jumping into kind of what we're all here for. As I'm sure you all are aware, decisions related to our transportation systems interact with so many consequential aspects of our lives. You'll see here, access to nutritious foods, education, employment. And because we know that transportation does impact health outcomes, and we know that it does play a role in public health. And it also means that we can apply the principles of public health and prevention in roadway safety work. And so, which brings me to the pyramid. As Dave highlighted in his overview of the safe system pyramid, we need to be prioritizing the strategies that impact safety for an entire community, for an entire population, rather than focusing on individuals or strategies that require a lot of individual effort. So for instance, kind of in the roadway safety world, the traditional approach might focus on a few bad apples or people who are doing dangerous speeds or high speeds, when we really need to be focused collectively on slowing down the speeds for an entire community, for all road users. And so when it comes to translating the safe system approach and the safe system pyramid, some of the ways we have kind of conceptualized this at Vision Zero Network is kind of changing the organizational practices and really thinking about the ways we can bake in safety into our planning and ongoing work. For instance, one thing that comes to mind is like currently repaving is often separate from evaluations for pedestrian infrastructure or biking infrastructure. So one way to kind of build this in is when repaving, thinking about opportunities for quick builds, whether there are don't have a lot of sidewalks, don't have bikeways, and are actually in built environments that encourage speeding. Yeah, and just to kind of shift to some of the ways I'll be talking about how the safe system approach and the pyramid can be applied to Vision Zero. Just a quick overview, I'll be talking a little bit about Vision Zero plans and how they differ from the traditional approach to roadway safety plans. Strategies that practitioners, both public health and transportation practitioners, can take to kind of consider and institutionalize a safe system approach, the role of collaboration, the role of kind of using a multitude of data sources and how we prioritize safety investments, how to operationalize for health equity, and being transparent and accountable to what we know works on our roadways. And so with that, Dave did a really good job kind of providing a high-level overview of the traditional approach. But just wanted to highlight, you'll see with the traditional approach or the E's, we have engineering, education, and enforcement. But you'll also see that compared to the safe system approach, which is at the bottom, safety is at the heart of the core pillars. You have safe streets, safe speeds, safe vehicles, and safe people. In addition, it kind of differs because it sort of implies that these are all kind of working in silos, that engineering is its own thing, education is its own thing, equity is its own thing, when they're all sort of used as tools in the name of safe streets. So it's also a difference in approach and kind of breaking down silos. This is not to say that the E's, particularly like enforcement or education, have no place at all in the safe system approach, but currently they're overemphasized or overutilized as strategies when we know that infrastructure in the built environment is going to be the most effective at cultivating safe streets. To kind of demonstrate this difference, I just highlight an example from Philadelphia's 2017 Vision Zero safety plan and their 2020 plan. The first plan states one of their Vision Zero priorities as being engineer streets to reduce risk of crashes. But when compared to their safe system approach, they've shifted that to creating roads that are predictable and aren't confusing for anyone using them. So it's already in that shift, it's already kind of breaking down silos, because it takes more than just engineering to make something kind of predictable and straightforward for all types of road users. It also mentions preventing fatal crashes by managing vehicle speeds. And so with safety being at the core of the safe system approach, it's really not about, working harder. It's really about doing things differently and prioritizing the strategies that we're not really utilizing enough. Which brings me to this next emphasis point of really institutionalizing versus adopting the safe system approach. Currently, and it's all very exciting, Vision Zero is getting a lot of attention and a lot of funding across the country, and we're seeing more and more communities commit to Vision Zero. But simultaneously, for a lot of the kind of more established Vision Zero communities, many are wondering, like, why aren't we seeing roadway fatalities go down? Why does it seem like, for many communities, fatalities and severe injuries only continue to increase? And I think a big part of that is because one aspect of Vision Zero and the safe system approach is adopting, but to really institutionalize these changes, it's a long road, for lack of a better word. Adopting is really just one step in a long process of actually doing things differently, of centering safety and focusing on proactive and preventative strategies. And as Dave highlighted, unless we really address this idea of kinetic energy, we're really kind of doing the same things. We're not changing how we're doing this work. And so to kind of highlight this for folks in the room, I essentially adopted the socio-ecological model to the safe system approach and sort of how strategies are being utilized in the roadway safety world. And you'll see, when adapted for transportation, it bears many similarities to the safe system approach, which asserts that, people are moving about in imperfect transportation systems that do not encourage safety, but rather the opposite. And so to encourage roadway safety, we've got to make safety the easiest and only choice, the default choice, and to think critically about which tools we're overusing and underusing. You'll hear me say this a lot, but I'm going to repeat it over and over again. So on the right-hand side, just to kind of emphasize this, we'll see like downstream is like education. Again, this is not to say that education doesn't play a role, but it does require a lot of individual effort, whereas upstream would be road redesign and complete streets. And this is, I just want to emphasize again, this is particularly important for communities, specifically low income and BIPOC communities, which are disproportionately kind of overburdened with dangerously built environments. And many of them are kind of being penalized via enforcement, which is a tool that's often kind of being scaled up in those areas. And so to kind of highlight and provide some real world context to this, just wanted to show this example from Seattle. They identified that high speeds were a leading contributor to serious injury and fatal crashes, particularly for people walking. And so the city began to kind of take a really proactive approach to setting lower speed limits across the city. And they did this in conjunction with road design features like speed cushions, bulb outs, beacon crossings. And they did this specifically without increasing enforcement and saw a reduction in speeds on 70% of their major roadways. Which brings me to another strategy of collaboration. I'm speaking to like lots of transportation practitioners often, and many times they want to collaborate with their public health department, but aren't necessarily sure how to. And so in our recommendations, we usually recommend, start with a Vision Zero task force. For those listening in, public health practitioners, I would really encourage you to see if there's an opportunity to reach out to your local roadway safety or Vision Zero task force and get involved. I definitely think it's a great opportunity to kind of build and combine perspectives and sort of see how roadway safety relates to public health. I think sometimes that collaboration is really necessary to help people kind of visualize. And to emphasize this, just wanted to highlight some work happening in Clackamas County in Oregon. They actually have a joint public health and transportation staff member who serves as a liaison between the two departments. And this person does health impact assessments for all county projects, including transportation. And this is now kind of baked into all of their safety planning and ongoing work, especially I think as well for senior housing, shelter housing, and kind of affordable housing initiatives. And so when I say collaboration, I really mean kind of institutional, I guess, dissemination of these public health principles in transportation and vice versa. To illustrate this is just kind of a different example of how this collaboration sometimes forms between public health and transportation practitioners, specifically in San Francisco. They are working with epidemiologists, trauma surgeons, emergency physicians, hospitals, and more on developing a transportation injury related surveillance system. Currently, a lot of roadway safety practitioners will use police data to kind of capture crashes. But we're finding that police crash data often undercounts for specific populations and doesn't often include severe injuries. And so this is also another opportunity to kind of facilitate. If you have access to data sets, I think your local practitioners would really appreciate having that information to kind of build out their high injury network or access to kind of understanding how these injuries show up in their community. Yeah, okay. And additionally, consider an array of data sources and prioritization. So it's kind of related to my previous point. And we're seeing more and more roadway safety practitioners do this. They develop a high injury network, which is essentially a map of all the roadways that kind of have the highest concentration of severe injuries and fatalities. But we're now really pushing to encourage practitioners to also layer on top of their high injury network demographic data or health equity data to really kind of visualize other indicators of vulnerability. And so to kind of highlight this, I have two examples, one from Philadelphia and also from Tampa. And the high injury network is shown by the red lines here. And in their high injury network, when overlaid, they found that serious injury crashes are 30% more likely to occur in communities of color and 3 times more likely to occur in low-income areas. Similarly, in Tampa, 52% of fatal and serious crashes occur in these areas that they deem as communities of concern, despite the fact that they only make up about 27% of city streets. Unfortunately, I probably could have taken this from any high injury network, any Vision Zero action plan, and this relationship will show up. And so it really does encourage us to really think about the ways that we can be planning and doing roadway safety differently and better for these communities. And in addition, just this point of operationalizing for health equity, we at Vision Zero Network have developed this definition adapted from Dr. Kamara Jones's definition. I'm not sure if you all are familiar with it, but essentially we emphasize valuing all people, communities, and their mobility needs equally, recognizing and rectifying transportation decisions that have exacerbated disparities, and providing investments in safety policies, practices, and infrastructure according to need and risk. Just want to bring particular attention to this final point. As I shared on my previous slide, we are seeing that oftentimes the high entry network will often be kind of overrepresented in low income and BIPOC communities. And so if we know that to be true, that means we also need to kind of be prioritizing all of our safety investments in those areas. Doing roadway safety audits, biking audits, walking audits, ensuring that there's no gaps in mobility there, instead of kind of relying on enforcement or education as a tool, recognizing the fact that these same communities are at risk, and we're also kind of penalizing them for the roadway, the built environment that they're living in. And so just to provide some examples of like what this operationalization can look like, I just highlighted this example from Oakland DOT. They developed a geographic equity toolbox to kind of track the distribution of investments, safety investments, and resources that they are doing across the city. And they've also done this with their near-term projects, or what we call like quick builds or tactical urbanism, depending on what you're familiar with. And so you'll see that they have put the majority of their quick build projects in their high priority equity communities, as well as kind of more robust capital projects, roadway redesigns as well. So this is something we're also kind of uplifting, like in addition to adopting an equity framework and setting goals, you also need to kind of be measuring and tracking like where your investments are going. And finally, my last point is just kind of being transparent and like accountable to what we know works, as they've highlighted in his presentation, as I'm highlighting, and as Meghan will also highlight. Kinetic energy is like a critical element in deaths and serious injuries on our roadways. And so in working towards a goal of safe streets and safe, equitable streets, we've got to look critically at whether the strategies we're continuing to uplift and utilize really yield the impact that we're looking for, and hold ourselves accountable to that. And so because we know that kinetic energy plays a big risk, we need to be designing our built environment in a way that kind of manages that transfer of energy. And so to kind of highlight this, I have shown this framework as well from Oakland DOT, in which they've developed this way of assessing the different strategies that they're choosing to utilize, in which I kind of highlight here this like the pyramid compared to the framework, which highlights kind of the active measures and education as yielding limited community level impact, or like far-reaching impact. And I wanted to highlight this specifically because this has kind of played a key role in like grounding their roadway safety work in what is shown to be most effective and equitable. And so in closing, while I initially developed this specifically for transportation practitioners, I just want to encourage you as public health practitioners, even in your conversations, whether it's with roadway safety practitioners or with your colleagues, just thinking about the fact that, we're currently utilizing or overutilizing education and enforcement when we really should be focusing on the built environment to kind of treat the root causes of high kinetic energy and high speeds, really focusing on population level strategies instead of like targeting individual behavior when it comes to roadway safety. Breaking down silos. So feel free to share our presentations or this recording if there's a transportation practitioner that you're kind of cool with, or that or want to start a conversation with. Yeah, thanks so much for listening. I'll pass it. Oh, one thing I want to highlight. Oh, sorry, one last thing. We do have a resource on our website, visionzeronetwork.org/health equity, that delves into a bit of these strategies that I highlighted, but it's all about health equity for Vision Zero practitioners. So definitely also feel free to check that out and share with others. I will now pass it to Megan. Thank you so much, everybody.
Hey, Dave and Tiffany. Great. Find my.
And Megan, just so no, we do wrap up at 2:50 or at 3 o'clock. So we have 10 minutes to squeeze in yours, but I hope folks will throw questions in, and just in case we get really close to time, I know you were going to send some follow-up information and ways people can get in touch, right?
Yes, we're planning to do that. Are you seeing my correct screen or my notes screen?
Correct screen.
Okay, excellent. Yes, I will jump in, and I like to frame my part of my presentation as I've been doing so much listening and learning, which has been really motivating for me in the work that I do. And it's nice for me to go third because I'm not the public health expert here at all, but I'm really the one who's able to translate how I think that applies to the transportation planning and engineering world that I sit in as a consultant in Fehr and Peers and as a representative from ITE. So that's kind of our counterparts, right, in terms of the professional organization for transportation and engineering. Motivating factor here and the sense of urgency, right? So we've got a lot of tools and new ways of thinking about it. And I think adding just onto that, why we have to learn this and why we really need to take this new paradigm and new approach is because clearly it's just not been working what we've been doing in the past, right? We're seeing worsening conditions in particular for pedestrian safety in recent years. And so the time is really now to be asking ourselves why are we not getting where we need to be getting? This iceberg image, I think, has been working for me in so many different levels to try to explain that why it's not working, right? So it's not working because we're only working at the top of the pyramid. It's not working because we're only have a few of us, the people in the safety silo or the people that are safety experts thinking about safety. And it's not working because we only have a handful of safety projects and the rest of our projects either don't have safety as a component to them or maybe are still working against our safety goals. So that's it kind of explains it, but it also really helps us to think through, okay, well, if we look below the surface, what can we learn and understand and do differently and emphasize in a different way to get there more effectively? And so certainly learning and listening and understanding that we've been prioritizing things at the top of the pyramid when we know and have the tools at the middle of the pyramid, and the learning and the partnership and the reframing, I think is what's really essential at the base. So it's all pretty intuitive when you think about it in this approach of why we're not seeing, why 10 years in Division Zero for many cities, we're not seeing the progress that we would want to see. And so that's, just we're going to reemphasize here around the E's and the fact that we have organized them in silos, but also missed the most important of the E's, which is that energy. And so if we're able to prioritize and think about this as the most important focus in everything we do, and also understand how, because we've been missing this, we've been kind of missing the point, it does really point pretty clearly to the shifts that need to happen. As system stewards, so that the people who are doing the planning and the engineering for the transportation networks, we need to be doing more, acting more quickly and more efficiently. We have to look upstream to broader planning and policy efforts happening in our communities. And then we need to learn a whole new tool set around change management and culture shift. And that's where a lot of us didn't learn that in school and need to be doing reading and attending webinars and collaborating because it's a different set of tools that we have to focus on, but it's the only way we're going to get to that base of the pyramid. Acting quicker and more efficiently, there's never been an easier and better time to have funding for safety. The bipartisan infrastructure law has a ton of safety funding in it. And so kind of no excuse on that front, but also unlocking funding for safety by doing safety through everything is a really important way to be thinking about this. Only doing the projects that are really have a nuanced focus on reducing the killed and severe injuries. And so not trying to hit every single collision, but really those locations and those types of collisions that matter the most for injury. And then really just collaborating across all different projects and departments to find safety funding and safety opportunities in everything. That's the difference between the implementation and the institutionalization mindset. Again, on the institutionalization perspective and the base of the pyramid, really understanding how parking is a safety strategy. Transportation demand management is a safety strategy. Mixed land uses, thinking about the jobs housing balance, understanding why people travel, where people travel as kind of the important framework, and also what can, really think about the upstream and the fundamental socioeconomic conditions that lead to risk as a more basic understanding and appreciation, but also a whole new set of tools and collaboration that we can be focusing on at the base of the pyramid. And then on that change management and culture shift, this is where the epidemiologists can teach transportation planners and engineers a lot. So I think there's a need for that task force and collaboration of the different disciplines, but there's also a need just for like having planners and engineers learn from the mindset and the theories and all the practice that public health has long figured out to be able to apply that. And this magic triangle framework is another one that I've been stressing, that we can't have just an engineer, planner, or safety champion and an agency carrying this alone. You've got to have the elected officials on board. You've got to have the capacity within the engineering and planning and consultant community to be able to speak to what we're talking about. And then you've got to understand and bring the advocates to the table, because they can really play that kind of accountability check and the longitudinal role as people may change, have different elected officials or have different staff. And really, really importantly, getting out of our own way. So many of the things that we should be doing more of are not new tools, right? It's not about doing a lot more research and inventing things. It's about understanding why the proven countermeasures that have long been available to us are not institutionalized and routinely being used. And that means we have to talk about level of service and parking, because often it's the case that we have just been systematically prioritizing reducing vehicle delay and promoting vehicle throughput in our communities, as opposed to thinking about where should we rightly be looking at movement and where do we more appropriately need to be looking at place and livability and multimodal optimization. I'll drop into the link. We had a really fascinating multidisciplinary collaboration at the Transportation Research Board meeting in January this year, where we talked about this overlap between safe system and public health and safe systems pyramid. And we created a list of all of the things we could do more of and the things that we need to do less of based on that learning and that understanding. And we wrote a paper that kind of reflected all of those key learnings and insights. And so that's something we can share from the ITE journal. The leading pedestrian interval that Dave talked about earlier is one of those great examples of what we should just be doing in every single traffic signal within our community, because it's so cheap and so obvious in terms of its impact, but yet we don't do it institutionally. And so why not? Asking that why not question for those really important kinetic energy reduction strategies can really lead us to understanding what those roadblocks likely are, and where that culture shift and change management has to come in to be able to shift us to do those things. There's some things to be cheering and to learning and appreciating in terms of progress we have made. This is just an example of, in the California context, things that we're doing. We're shifting from level of service to VMT, to thinking about homelessness and kind of some of those like really larger socio-economic issues that we have to be dealing with. And at the top of this, the change in our ability to set speed limits with AB 43. So a lot of these things have been scattered and done by different people in different departments with different focus areas, but the pyramid gives us a chance to bring those together and to celebrate. There's a lot more to be done, but there also has been a lot already achieved. And I know I'm really rushing through this. So let me just wrap up by saying ITE has been taking a huge leadership role in this and really trying to make sure that we're sharing and being the conduit, but also looking in the mirror and understanding the Safety Council should not be the only place where the conversation about safety is happening. The entire institute has to be a place where safety is the default. And we've got to figure out if there are things that we continue to do that are counter to that, or if there's capacity building that we need to do so that everybody is a public health practitioner and a safety practitioner within ITE. The same thing with organizations such as mine, that we have a safety discipline group, but we also have a forecasting discipline group. We also have land use. We have a lot of people working on evacuation planning. Everybody in my organization needs to be able to speak and understand the tensions and the win-wins and ways to reconcile and collaborate across those silos. Okay, hopefully I got there. I know I rushed through a little bit, but I want to respect everybody's time and hopefully tie together some of the key insights from the previous two. We really appreciate the chance to be able to join your meeting today.
Yeah, thank you. Thank you so much. And this recording will be shared out so folks will have it. I will turn off the recording. It looks like we can linger for a few questions maybe.